All right. I want to thank everybody for joining us. Hope you're all staying safe and healthy out there. This has been really a great forum for the fellows and faculty to exchange ideas and really learn from each other. And really want to thank everybody for joining us. So every week, the HAM fellows have done a phenomenal job and really appreciate their outstanding presentations and also the discussions by the mentors throughout each of the virtual debates. Hopefully things are normalizing for most of us across the country. So this initially started as more of a face-off, kind of a one-on-one virtual debate, little trash talking, and last couple of times it's turned into more of a cage match instead of one-on-one. Last 2 weeks ago, we had Jeff Yell moderating a Scaphoid Lunate session with 5 different competing institutions. So this week, we're really excited to welcome University of Cincinnati, Beth Israel Deaconess at Harvard, University of Pittsburgh, and also Philadelphia Hand Center. So this week, we're going to be looking at DRUJ, specifically DRUJ Arthritis. As the fellows have kind of learned throughout the year, and I continue to certainly learn myself as a faculty, it's a very complex joint. What makes it really complex is really minimal bony restraint. So it really could depend on soft tissue, including the DRUJ ligaments, dynamic stabilizers, and the joint capsule for stability. So post-traumatic arthritis instability is fairly common. As far as what could cause DRUJ arthritis, this could be an inflammatory process, could be a rheumatoid patient who might be on DMARDs and biologics that's not controlled. It could be degenerative, wear and tear over time. Post-traumatic arthritis could be a prior distal radius malunion, a physeal injury, or perhaps a congenital condition such as Madelung's that can lead to DRUJ arthritis. What makes it really, really challenging is treatment options include resection arthroplasty with a Darrach or Hemi-Resection, arthrodesis with a Suave Kapandji type of technique, or ulnar hair arthroplasty. I think as the speakers will talk about later, I think some of the challenges include trying to control the ulnar stump. And even the DRUJ, if you're looking at just the ulnar head prosthesis, how do you control stability across the distal radial ulnar joint? So not only do we have to contend with the DRUJ, it's not just arthritic. So you have loss of bony articular cartilage. You also have instability. And then some patients could have concomitant ulnar carpal impaction and also radial carpal pathology as well. And again, the distal ulnar stump instability remains a really difficult challenge. So we have a couple of cases that I'm going to be presenting to the panel and that our fellows will be debating on. And we're going to be also having a poll to really look at what the faculty and the fellows would do for each of these cases. So case number 1, this is a 67-year-old with seronegative rheumatoid arthritis with a 2-year history of wrist pain. She's tried DMARDs and methotrexate. Her small finger extensors actually started to become weak with a risk of attritional rupture, limited forearm rotation. Wrist flexion extension is not too bad, but the DRUJ sublux with quite a bit of crepitus. These are x-rays here. You can see fairly severe erosive arthritis involving the DRUJ with gross instability across the distal radial ulnar joint. Case number 2, a kind of very different type of patient, 48-year-old. It was a motocross racer with a several-year history of wrist pain, had a debridement, kind of a minimalist approach at an outside hospital, a little bit of forearm supination and flexion extension. Again, he's got a DRUJ that's fairly unstable with a crepitus on the Lawman range of motion as well. And these are x-rays we're looking at here. This is a patient that's telling you, me outright that, look, afterwards, I'm going to do whatever I want. No restrictions, no limitations. I want to be able to do, I want to race. I want to do every activity possible and not worry about it. So kind of based on that, we have our panelists here today. So kicking off would be Dr. Chris Bates with mentor Peter Stern, looking at Darrach and Hemi-Resection interposition with some type of stabilization. Followed by Amanda Walsh out of Beth Israel Deaconess, mentored by Tamara Rosenthal, who will be advocating for the Suave Kapandji procedure. And number 3 with Dimitrios Papadopoulos from Pittsburgh, mentored by Dean Sotorianos. And lastly will be Chase Klumper, mentored by Dr. Zuluf out of Philadelphia Hand Center, advocating for implant arthroplasty. So this is really going to be based on case number 1 and case number 2, but I'm also going to be polling the audience on 3 other cases. Now you have a 44-year-old who had, you can see from here, has a prior injury to the wrist. She remembers a scaphoid non-union with distal radius bone grafting, but again, ulnar side of wrist pain. She's a teacher, relatively low demand. So you can see here, she had a lunate facet fracture of the distal radius that led to a post-traumatic arthritis, as well as ulnar carpal abutment. And then case number 4 is a 36-year-old female with a history of injury from physical abuse as a child. This is a physeal injury. You can see gross deformity of the ulnar head with impingement and convergence of the sigmoid notch. And these are x-rays here. And this is a very active 36-year-old female who wants to kayak and snowboard and do everything she could possibly do and be a very, very active 36-year-old. And then we have a case number 5 in a failed DRUJ. And again, be interested to see what the faculty would do and also the participants on the panel with us on what they would do for a patient like this who had a DRUJ procedure. And about 2 months ago, who's now back in Seattle for the summer, who's a snowbird. And pretty impressively, 2 months post a DRUJ resection with a stabilization procedure, had stump instability with convergence. So with that, I'm going to turn this over to Dr. Bates from Cincinnati, who will start off with DRUJ Hemi-Resection. Thank you.
All right, how are we looking?
Good.
Good, all right. So my name's Chris Bates. I'm a University of Cincinnati Hand Fellow. I'll be talking about DRUJ Arthritis, resection, arthroplasty. Patients come in with a variety of complaints, as already elicited: decreased form rotation, pain, strength, and tendon rupture. There are several options that are already listed. I'll be focusing on resection arthroplasty, specifically DRUJ, and hemi-resection interposition technique.
Hey, Chris. Sorry to interrupt you. Is there more than one computer near you? It looks like there's a big echo in the background.
Yeah.
So Peter Stern and Warren Hammer need to mute.
Can you mute your microphone? You shut it down. How does it sound now? Is it much clearer now? Yeah. Okay, good. So I'll be focusing on hemi-resection and DRUJ, the hit described in 1985 from Bowers. There are several other options that's already listed. I won't repeat those. The DRUJ, defined as the excision of the distal 1 centimeter of the ulna, first described in 1912 by W. Darrach. And I think it's great to think about how many procedures have stood this test of time and lasted 100 years. There's been several studies on the DRUJ since that time. A quick summary of the literature: there are several studies that report good results in Journal of Hand Surgery back in 1990. Improved range of motion and grip strength. 90% of patients reported good or excellent results. 1996 JBJS in British version, 85% of patients subjectively satisfied. 2012 JHS Growie et al. 13-year follow-up, overall generally favorable. And they had dynamic convergence on a few patients, but clinically not very symptomatic. There are some results that are not so good. 1985 showed ulnar impingement, weak grip, some pronation, superfusion difficulty. And then JBJS in 1993 had 50% of patients with poor results. Obviously, I'm supporting the DRUJ and the hip, so I want to draw your attention to the left column. Several good results, 1990, 96, 2012, showing even in some patients with dynamic convergence, it didn't seem to correlate with any clinical symptomatology. There are some legitimate criticisms of the DRUJ, specifically radiographic convergence, dorsal palmar instability in some patients, weakness with forearm rotations in some patients, occasional extensor tendon rupture, and then bailouts for this procedure are not ideal. There are several varieties out there, from soft tissue stabilizations with ECU, SU, several different options, implant arthroplasty, allograft interposition, wide resection, and even a 1-bone forearm. There are several advantages, however, to the DRUJ. It's been around for over 100 years with at least several studies that show decent results. It's a very simple procedure. It can be done by lots of different people, and good outcomes. If you want to do a brief meta-analysis, maybe about 80% of the time. Some of those disadvantages we already listed, instability, and then the bailouts aren't that great. To discuss hemi-resection interposition arthroplasty, first described in 1985 by Bowers, you can see that it's a little bit different in that it only resects the radial portion of the ulnar head, preserving the ulnar lunate and ulnar triquetral ligaments, the TFPC complex, the ulnar styloid. After that resection, the space was originally filled with a tendon anchovy. In his original study of almost 40 patients, combination of rheumatoid and trauma, 85% of rheumatoid patients had good results, and 100% of patients with trauma had painless pronation. There are some criticisms specifically for residual pain, some instability. You can get ulnar styloid abutment as emphasized by the universal symbol for pain, the lightning bolt. You can get a styloid fracture with additional resection and instability, ECU tendonitis, and even impingement similar to the Darrach. So which patients would we recommend Darrach for clearly? Distal radius fracture, malunion, loss of forearm rotation with isolated DRUJ incongruity leading to DRUJ arthritis, especially if they're lower demand, elderly patients, and then definitely in patients with rheumatoid arthritis. A little pot shots at the other procedures. Suave Kapandji, you got prominent hardware, painful hardware. You have hardware, you don't have that in the Darrach or the hip. It's not a lot of skin and soft tissue covering that ulnar side that can back out and cause lots of problems. You have to get a fusion. Some patients have a high risk of non-union, AVN, problems with that. And you can actually get a fusion where you don't want a fusion. You can have broken hardware leading to further pain, surgery, not solving the problem. This patient went on to get a Darrach. They probably did great. I don't know. When it comes to implant arthroplasty, you have an implant so you can have actual dislocation. Again, due to the difficulty with soft tissue stability, you can get an infection requiring further surgery to resection, especially if there's biofilm formation. You can get loosening, and then of course erosion anytime you have a metallic implant going on native cartilage. Then one bone forearm, there's some great studies and great quotes here. 1995 Mayo study, non-union in 30%, only about 30% of patients had excellent results. There's a great thing out of Philly Hand from 2013. Although the wrist and elbow range of motion was spared with this procedure, pain persisted and functional outcome was poor. This was their last resort. So in summary, it's a complex problem full of caveats. Dynamic conversion doesn't seem to correlate with clinical outcomes in some studies. So resection arthroplasty, Darrach and Bowers, excellent option in the right patient. They were simple procedures with overall good outcomes. Thank you for your time.
Great job, Chris. Thank you so much. So next up is gonna be Amanda Walsh, who will be advocating for the Suave Kapandji out of Beth Israel.
All right, hi everybody, thanks for having me. So I'm Amanda Walsh from Beth Israel, and my mentor is Tamara Rosenthal. I'll be talking about the Suave Kapandji procedure. There have been many surgical treatments for symptomatic DRUJ arthritis without one clear superior procedure based on literature. I today will convince you, however, that of the available options, the Suave Kapandji procedure is the most versatile and the best first choice in most patients. Before we talk about the merits of the SK, let's briefly review why the other options don't beat it out. We'll start with the Darrach procedure. While a good procedure in select low-demand patients, the Darrach has narrower indications than the SK. It's typically avoided in younger, high-demand patients due to the potential for decreased grip strength, volar ulnar shift of the carpus over time, and painful radial ulnar impingement. In several direct comparison studies, some of which I've listed here, the SK was found to be more effective at reducing pain, improving function, reducing ulnocarpal translocation, and improving grip strength. Interposition arthroplasty is another potential procedure. I would argue that its place in this talk is as a salvage procedure, which is exactly how it's been described in the literature with good results. However, the use of allograft introduces the risk of foreign biologic material as well as additional cost. While the idea of a fluffy pillow is appealing, we need more data before we consider this a primary option. DRUJ arthroplasty is the newer tool on the block, but I would again argue that it's not the best choice for a first-line treatment. While results published by the creator of the arthroplasty are promising, it doesn't seem that these excellent results are generalizable quite yet, as evidenced by 2 recently published series. These 2 studies out of Mayo and University of Washington had a 29 to 44% complication rate with an up to 10% explant or revision rate. Just as important as the rate of complications is the severe nature of these complications. Infection requiring explant and revisions, periprosthetic fracture, severe tendon complications, and wound healing issues have all been described. After failure of a prosthesis, there are few options for bailout, and the patient may end up with the dreaded 1-bone forearm. So now, on to the more positive portion of this talk. Why is the SK the clear winner? Firstly, of the procedures discussed today, it's the most versatile with the broadest indications. Unlike interposition or prosthetic arthroplasty, it has a low potential for wear and has well-established longevity. The ulnar column remains intact, completely preserving the TFCC, ulnocarpal ligaments, and dynamic stabilizers of the wrist joint. While performing the procedure, ulnar variants can be corrected to address ulnocarpal abutment if needed. And lastly, cost is not an insignificant factor here. The SK is a simple, cheap, low-tech option with reliable results. Let's look at some of those results. In 2005, Zimmerman et al. Published their series of 105 patients who underwent SK and found a 97% pain relief and improved function. Notably, there was a high rate of radial-ulnar convergence, but this was not clinically symptomatic all the time. Additionally, they did not routinely do soft tissue stabilization of the ulnar stump. A recently published study from our institution demonstrated the versatility of SK with significant functional improvement in both inflammatory arthritis and osteoarthritis at 1 year. All patients had improved range of motion, particularly in supination, which is often most severely affected. There was a relatively high complication rate in our study. However, most of these occurred early on in the 10-year collection period. Additionally, these complications were mostly minor, often hardware related, and are easily addressed with slight adjustments in technique, which I'll go over now. I'll briefly discuss the technique here, specifically relating to concerns of reossification of the osteotomy site, ulnar stump instability, and symptomatic hardware. During the approach, care must be taken to minimize soft tissue dissection, to maintain the integrity of the TFCC, the 6 extensor compartment, and ulnocarpal ligaments, and avoid injury to the dorsal sensory branch of the ulnar nerve. The osteotomy should be kept distal to maintain interosseous membrane attachment to the proximal ulna to maximize stability. Prior to osteotomy, the guide wires for the screws can be placed in the ulna and used as joysticks to correct ulnar variants if needed. After preparation of the articular surface and creation of the osteotomy, making the distal cut first, the distal ulna is reduced to the radius. The arthrodesis site is secured using 2.0 or 2.4 millimeter countersunk screws or headless compression screws, and the osteotomy site is packed with bone graft from the resected ulna. To enhance stability of the proximal ulna and interpose soft tissue into the pseudarthrosis site to prevent unwanted fusion, the pronator quadratus is then repaired to the osteotomy site using transosseous sutures. If desired, the ECU or FCU tendon can also be used for additional stabilization of the proximal ulnar stump with excellent results. As discussed on the last slide, many of the potential pitfalls of the SK can be avoided with the slight adjustments in the technique that we described. Non-union of the arthrodesis site is a theoretical concern. However, reported symptomatic non-union is very rare, 0% in most series. Both reossification of the pseudarthrosis and ulnar stump instability can be minimized with soft tissue interposition and stabilization. And symptomatic hardware can be minimized by countersinking screws or using headless screws. In summary, the SK is a versatile, reliable procedure for DRUJ arthritis that can be applied to most clinical situations. It maintains soft tissue stabilizers of the wrist and the ulnocarpal articulation. It's simple, reproducible, and cheap, and can be applied well in most clinical scenarios. As the only female team on the debate today, I'd like to remind all my competitors of a very important life lesson. Thank you.
Great job, Amanda. Thank you. That was great.
Thanks.
Pulling out punches a little bit. It's great. Right. So next up, we have Dimitris Papadopoulos from Pittsburgh, who will be advocating, arguing for interposition arthroplasty as a potentially primary procedure.
Hello. Yeah, hello. Can you hear me?
Yeah. So we're going to echo as well, Dimitris, from your computer.
Yeah. Is it better now?
Try again. I think we're getting a little bit still.
Okay. So my name is Dimitris Papadopoulos. Excellent talks from the previous fellows. But in the following minutes, I'm going to prove why the Achilles tendon allograft interposition is the best way to treat DRUJ arthritis. So these are all the options that we have for the treatment of DRUJ arthritis, and tonight we're discussing about the first 4 options. And the term interposition arthroplasty can refer to the HIT procedure where basically small retinacular flaps like this are interposed, or tendon rolls. Usually the palmaris locus is interposed, but I'm going to talk about bulk tendon allograft interposition, as Dr. Styrianos described approximately 20 years ago. And yes, this is the first study about this technique in patients with failed Darrach procedures, but nowadays more and more surgeons are using this technique as a primary procedure for the treatment of DRUJ arthritis, especially in young patients. And there are a couple of studies so far about the results of this technique. I'm going to say just a few things about the technique. So the ulnar head is completely resected if it's not already resected, and then we're exposing the medial cortex to the radius by placing these 2 homans underneath the radius. And then we're placing 3 to 4 suture angles into the medial cortex of the radius. That's proximal to the sigmoid node, basically where the radial-ulnar convergence occurs. And then we're creating this bulk allograft, and we're passing the sutures of the anchors through the allograft, and we're tying down the allograft basically between the radius and the ulna, as you can see here in these pictures. And the rationale behind the durability of this technique lies on this experimental study performed in UPMC about the allograft incorporation in thumb CMC joint interposition arthroplasties in primates. And the authors found that the interposed Achilles tendon allograft shows signs of vascularization and fibroplasia, basically adheres to the adjacent bones through collagen fibers. So if these results are applicable to DRUJ as well, then the potential exists for a lifetime cure. And this is the most recent study about the results of this technique, including 26 patients, osteoarthritis patients with a follow-up more than 6 years. You can see the functional results are good, as they are good with all the other techniques. But the complication rate of this study was 3.8%. There was only 1 failure. And we're seeing this side-to-side conversion between the Suave Kapandji and the allograft interposition arthroplasty. The Suave Kapandji has all these in theory advantages of preservation of the ulnar head, like better joint loading. The contour of the wrist is more normal, but this on the other hand requires adequate head, which is not always the case. And there are all these problems with the ulnar stump, like radial-ulnar convergence and gross instability, maybe palmar or dorsal instability. And the osteotomy site can be reossified, which will require a second operation. And this is an excellent, very recent study, an excellent study by the Beth Israel group that you just heard. And yes, the results were good, but the complication rate was 21%. And although some of these patients had minor complications, 9 patients required second operation, which means basically 15.7% reoperation rate. Moving on to this head-to-head comparison between the distal ulnar resection and the allograft interposition. The distal ulnar resection has all these problems associated with the ulnar stump, like stylocarpal impeachment, if we're talking about hemi-resection arthroplasty, or the most common radial-ulnar impeachment, or gross, again, ulnar stump instability. And this is one study with a long follow-up about the results of the Darrach procedure, 13 years follow-up to 27 patients, and the results were again good. The DAS score was 17 points, but again, 6 patients in this series required additional procedure, which again means high reoperation rate, 22%. And last, this side-to-side comparison between the implant arthroplasty and the allograft interposition. Yes, the implant arthroplasty has indeed the advantage of preservation of the normal DRUJ kinematics, but the ulna can be unstable, especially if we're talking about total ulnar head replacement. And the implants can be loose, or they can cause chondrolysis or infections, all these problems that they are associated with the implants. And this is a recent study about 52 patients with a total DRUJ arthroplasties. And there was 19 complications, and basically 29% of the patients required additional surgery. Again, same results, another recent study, 2019, 50 total DRUJ arthroplasties, but the overall complication rate was 44%. Basically, 1 out of 2 patients had a complication. And just to be honest and clear about all the results in the literature about our technique, so there is this study from Belgium about 7 patients with failed Achilles allograft interposition. And yes, we agree that there are reasons for failure if you do not stick to the technique. So if you do not secure the graft between the radius and the ulna, the allograft can dislodge. Or if you do not use a graft large enough to prevent the impingement, basically you will end up again with convergence. So if you're gonna do the operation, just don't do it like this. Completely resect the ulna head and use a bulk allograft. In summary, all these other techniques have good functional results, especially in low demand or RA patients, but the complications rate is high and the reoperation rate is high. And so the allograft interposition of plastic is better not because the results in the literature are better, but there are specific reasons for that. We don't use any hardware implants, so we don't have to deal with problems like this, infections and good problems, or loosening. There is robust fixation of the ulna to the allograft radius structure, so we don't have to deal again with problems like gross instability, like dorsal instability of the ulnar stump. And we completely resect the ulnar head as opposed to the hemi-resection, so we don't have any stylocarpal impingement. And then most important of all, we're using bulk interposed material, so we're preventing and avoiding radial-ulnar convergence. So in summary, I want to highlight that based on the experimental studies that the allograft incorporates on the bones, our technique has the potential for a lifetime cure. And I want to close with this line, one of Dr. Dean's favorite lines. So when you're holding a hammer, everything looks like a nail. So if you're gonna use one technique, just do it as it's supposed to be performed, and always, but always stick to the indications. Thank you.
Great job, Demetrius. Thank you. Right, and our fourth and last presentation is going to be Chase Klumper, mentored by Dr. Zuluf out of Philadelphia Hand Center.
Okay. Can you guys hear me?
Yep.
All right. Thanks to the faculty for being here. I appreciate your time. Thanks for my co-fellows for making the argument for me with their presentations. Unfortunately, I don't have any disclosures to today. I wish I did. So we're going to want to keep in mind the goals of this debate, talking about 3 main things: stability, motion, and a painless DRUJ. These goals are similar between both the 35-year-old post-traumatic patient as well as a 65-year-old rheumatoid. The post-traumatic obviously has a higher activity qualification. He wants to go out and do things. He wants to have load transmission. And this RA patient, as you mentioned, Dr. Wang, actually has really good range of motion and wants to be active. She's only 65. So while she may have some ligamentous incompetence, she needs to do things, more things in her life than knit. So I'd like you to think of these treatments as an evolution, starting at the turn of the 20th century with the Darrach and coming into the future and current day with implant arthroplasty. So all of these procedures are ablative procedures, the ones previously described. They significantly alter the biomechanics of the wrist, and so it's no surprise that there are a lot of complications from this, and all of them have been mentioned, but convergence, impingement, and the like. So the Darrach, let's not forget, was invented 100 years ago, as Chris pointed out, and prior to World War I, when they were using ivory and total knees. And there's no wonder that there are a lot of problems with it. Dr. Stern has gotten some excellent results from it, but a lot of other people have mentioned the problems, including 60% convergence. No one has mentioned, I don't think today, the ulnar carpal translocation that is very common, not to mention extensor tendon problems, cosmetic appearance, scalloping, and impingement. So this is an all too common clinical scenario in X-ray when patients come in status post-Darrach. Sorry, Cincinnati, but I think we can do better than that today. The SK was in the 30s, came about as excellently described by Amanda. It, in theory, does work to preserve the distal ulnar soft tissues. It fuses a painful joint, but in reality, you have impingement that's continued, as you see in this X-ray here. You have new issues with non-union and pseudoarthrosis, and you have continued carpal translation, not to mention the ulnar stump instability and this narrow window for indications as described by Dr. Blank and Dr. Lee and Hausman. This is also a too familiar clinical scenario where a patient with an SK has a painful click and clunk with pronosupination and has extreme pain from that. And sorry, Boston, but I think we can do better than that today. Allograft interposition arthroplasty, Dr. Sirianos' procedure certainly improves upon that and is, in theory, another great idea, but there are a subset of patients, I think, that have continued pain and convergence, and that's been described. And the answer, the real thing is that it's hard to resist multi-directional instability with only soft tissue. So you get patients that still have a painful wrist, and I think, Pittsburgh, that we can do better than that as well. But there's no question that it's a difficult problem. And so what's the answer? I think, as you can see from Mr. Iverson's forearm here, that DRUJ implant arthroplasty is the answer. Stepping back a moment, it's divided into unconstrained and constrained devices. We'll be talking about both briefly here. The ulnar head replacement is largely what most people mean when they speak about unconstrained devices. Started with Dr. Swanson in the 70s, moved through the 90s with Dr. Herbert, who changed silicone to ceramic. Dr. Berger in the early 2000s came out with the Avanta. And then today we have partial ulnar head from a couple different companies that is kind of a creative, novel way to replace just the articular component while maintaining the osseous integrity and the integrity of the soft tissues. And the survival in a recent study about 6 years ago now is 90% at 15 years. The Aptus implant designed by Dr. Shecker is the elephant in the room. Certainly excellent for stability, for load transmission, which none of the previously mentioned procedures can offer. You don't have to worry about the soft tissues. You don't have to worry about ulnar variance, perhaps a missed interosseous membrane injury. It's extremely versatile. You can use it for primary or revision. You can treat osteoarthritis, rheumatoid arthritis, mad lungs, malunion. And thankfully we have some literature to quote. This is from Dr. Shecker's group on patients under 40 years, 95% survival at 5 years with active patients that are lifting up to 40 pounds. We also have literature on the RA population, 19 arthroplasties, age 57. 12 out of 15 were satisfied with their lifting capacity, which the other procedures are less successful at, in my opinion, and none had continued ulnar translocation. We've learned that more procedures on the DRUJ equals more pain, and with this one, you can be one and done. And it's one thing, admittedly, for the inventor of a procedure to publish good results on it, but this is not the only author. There are a lot of respected leaders across the country who have published good results on this implant. Dr. Kayaker and Dr. Berger had 90% retention at 4 years follow-up with only one revision. We also had allograft interposition failed, and as one of the previous contestants mentioned, this paper converted to an Aptus with excellent outcomes, significant improvement in VAS, DASH, and patient-reported wrist exam. Dr. Jupiter has published on this. His pre- and post-op subjective global risk scores were impressive. And he's also kind enough to share some personal communication with me about it. And he thinks that the DRUJ has been very successful. It's useful to restore the malalignment, length discrepancy, and instability, and has a predictable longevity in his hands. And I'd argue who is more trustworthy than Dr. Jupiter. Maybe Dr. Hanel. As everyone has already mentioned today, that Dr. Hanel published his complications. And yes, they were, as you can see here, he had a number of different reasons. But I would argue that with a new procedure, a new implant, you're going to have a learning curve. And I think we're seeing that the complication rate is coming down. In fact, he was kind enough to go through all his complications with me and offered a solution to each one bullet point by bullet point. He had a couple caps loosened, which other leaders have talked about, including Dr. Osterman today. This was a design flaw that was corrected in the system. He had HO around the implant. He started using a long stem. He had 2 tendon adhesions, and he started moving at 72 hours, hasn't had any more. ECU tendonitis is a common complication, but a retinacular interposition has solved that. He did have 3 late infections at an average of 8.5 years, and he now covers dental work with antibiotics for that. He had some dorsal sensory nerve neuritis. I think that's pretty common with all these procedures, but he now uses a specific incision, which actually was described by Shecker, and altered his retractor technique. He had patients, which I thought was interesting, they complained of their elbow afterwards because they got such good motion from the Aptus that their elbow started hurting. And so now he looks for preoperative, radial head malunions or limitations in elbow range of motion. And he also had stress fractures, and now he does a unicortical screw proximally to limit the stress riser. Again, he's down to 2 complications in 31 patients of his last subset. And that's seen across the country. All of these studies, 49 patients, 0 revised, 2 infections, Jupiter 600, another group, Savido 2700, Rampazzo 46, 2 revised, 1 infection, and then Dr. Hanel's current study, I think is up to 52 with 5 and 3. So if you average these out, it's 3% at 5 years complication rate. The total the total knee arthroplasty revision rate is somewhere between 2 and 6% at 5 years. So we're right there on course to match that. So what's the short and sweet of the implant? These are the take-home points. It provides stability, pain relief, motion, load transmission better than any other options. It's extremely versatile. It can be one and done, meaning you don't have to take these patients along, and they may not be the healthiest patients to put under anesthesia, especially the RA ones. It has a low revision rate, which is getting better. And it's the ultimate fixer. You have a patient with multiply operated patient. This is the answer. And finally, I've learned actually from Dr. Zalouf that you don't argue with a legend, because when you do, that's what happens. Thank you.
Right. Great job, Chase. Thank you so much. So great job, Dr. Bates, Dr. Walsh, Dr. Papadopoulos, and Dr. Klumper. So great job, all 4 of you. So I'm going to actually open up a poll now, and hopefully you could all see this. Everybody see the poll on there? So if you could go through and answer. So question number 1. So in your opinion, which fellow gave the most compelling argument as far as the best treatment? And if you recall the cases, I kind of gave a short summary. So I have a 67-year-old low demand rheumatoid, what would be the treatment of choice for you? And as you go down, if a 48-year-old high demand male with post-back arthritis, what would you do? 44-year-old, that's a fairly low demand with post-back arthritis with ulnar carpal impaction. Your 36-year-old high demand with a fascial injury. And lastly, question number 6, if you have a DRUJ resection that was done either by yourself or another surgeon with convergence and instability, what treatment option would you choose? Would you revise the stabilization, do an interposition a la Dr. Sartoriano's, implant arthroplasty, or refer to a senior partner or a legend, a la Dr. Hanel, Dr. Osterman in the audience? Some of you, let's go. If you could please vote as much as you can. I'm going to try and tally the votes here.
Jerry, while you're telling the votes, Doug and I have shared a Monday afternoon hand clinic at Harborview for the last 30 years. And I will tell you, whenever I get a bad DRUJ, I give that patient to Doug to do an interpositional arthroplasty.
Nice.
to do a checker. Yeah.
So I'm going to give this another kind of 15 seconds here. The votes are coming in. So Doug, I might be sending you some patients coming up. Just beware.
Well, I'd be glad. I'd be honored to take care of your patients. You don't have many complications, that's for sure. So.
All right. So the poll is ending. Again, outstanding job by all 4 fellows. Very compelling arguments, all 4. So can you guys? The results are coming up now. So looks like kind of Dr. Klumper drew the last punch with his evolution argument for the implant arthroplasty. So we'll be kind of asking each of the 4 faculty who are mentors on each of these cases, but it looks like despite some of the limitations of a DRUJ resection, I think on a low demand patient, a rheumatoid, I think it's still the preferred treatment amongst the participants, 56%. But I think as we go up to a high demand patient, I think now we're looking at kind of a split between a Suave Kapandji and the implant arthroplasty. I think with the lean towards a Suave Kapandji, I think perhaps with concerns of the implant, perhaps periprosthetic fracture or loosening. Then we go to a 44-year-old, so this is still a relatively younger patient, but lower demand. We have a split down the middle with all 4 procedures about 25, 25, 25, 25%. And back up to a high demand female who wants to kayak or snowboard. Based on this, I think there's certainly concerns of convergence, so either interposition or implant arthroplasty. And lastly, your 78-year-old who's now had a failed Darrach is, what would you do? And I think the implant arthroplasty seems to be the procedure of choice, or refer to Dr. Hanna, Dr. Osman, Dr. Stern, and Dr. Jupiter. So with that, I'm going to show you what I did on each of those 5 cases. And then I'm going to start with Dr. Stern and go on to the other faculty on their thoughts. All right, so case number 1, this is a rheumatoid patient with erosive changes, quite a bit of scalloping of the sigmoid notch. So I kind of agree with the majority here. So instead of a Darrach, I actually did kind of a Darrach combined with a interposition with allograft, as described by Dr. Statorianos. So that's case number 1. This high demand motocross racer who's going to kind of do what he wants. So my concern is I think the soft tissue interposition is not enough for him. So he ended up with a Suave Kapandji, so kind of matches with the majority here. So this is a kind of similarly younger patient with post-traumatic arthritis and impaction, but a little bit lower demand than the motocross racer. So she ended up with a Shecker. I think she promised to be compliant as much as I trust her to be compliant. And a kayaker snowboarding. This is kind of an unusual injury and presentation. I think Suave Kapandji a little bit tougher based on her ulnar head deformity. She's a kayaker. She has several different problems we're dealing with here. So she ended up with a kind of a mushroom cap Hemi-Resection with interposition arthroplasty. And this is the type of patient you had in your practice every single week with a DRUJ pathology. She actually won a paddleboarding, 2nd place in paddle surfing a year later. So very, very happy. Certainly good to be lucky. And that case number 5, a failed Darrach with convergence, ended up with a Shecker prosthesis. So that I'm going to turn to each of the faculty. So let's start with Dr. Stern. So great job by your fellow Dr. Bates. So you guys talked about some of the limitations of a Darrach procedure. So what's your true algorithm? I think on a rheumatoid, is the Darrach your procedure of choice? And then on a 45-year active male or female, what would you choose?
Procedure of choice. I think, first of all, I think the carpal translation in most patients is a myth. You've got very strong radiocarpal ligaments. There is always the risk. Very happy patients.
What about on your kind of a high demand patient? Do you rule out a Darrach procedure completely, and do you do that with an interposition or perhaps an implant?
To a Darrach procedure. As Chris mentioned, the major problem with the Darrach is that when it goes south, it's hard to salvage. Your choices were all mentioned except Scott Wolf wrote kind of a collaborative study in which he did a very proximal ulnar resection at the junction of middle and distal thirds of the forearm and had actually very good results. But prior to Lewis's implant, most failed Darrachs were often salvaged with a 1-bone forearm. And I agree with whoever mentioned Peterson's study clinic. There's a very high non-union rate and complication rate with a 1-bone forearm. And a 1-bone forearm is moderately disabling, as and the Philadelphia group has published.
Okay, great. Thank you, Peter. So Dr. Rosenthal, tomorrow. So I mean, SK in your hands obviously works really well. You've published on this as well as your colleagues. So is that your go-to for even a 75-year-old rheumatoid patient? Are there any limitations of the Suave Kapandji in your hands as far as indications?
It really is my go-to. I think I tend to use it, and anybody who's high demand in a rheumatoid who has decent bone stock, in which I don't think a fusion will be hard to accomplish. I think the only caveat are people who have, obviously, if you've had a failed DRUJ or a failed implant, then those are not amenable to an SK, and those are cases where I would probably use an interpositional arthroplasty. I do not like implants in the DRUJ. I think longevity is a huge problem, and there's no way I'm putting that in a 44-year-old.
Is a smoker a contraindication for you for a SK?
Is a what? I'm sorry?
Somebody who's a smoker?
5 minutes.
No. I have not had any trouble with SK arthrodesis. I mean, a lot of people don't even prepare the joint surfaces and just put the screws without preparing them. I do tend to decorticate them, but I have done them in smokers and rheumatoids and immunocompromised, and just that particular complication has not been an issue for me.
Okay. And then lastly, if you have an SK that does have ulnar stump instability, what's your kind of bailout? What's your salvage for that?
So the first thing I would say is that I think the ulnar stump instability takes a little bit of time to resolve. It tends to be worse immediately post-op. And then as some scar tissue forms and patients build up muscle, it improves. So I often tell my patients that it takes a good year to get to their new baseline. I've really only had a handful of cases that have required revision surgery for it. And I do not do an FCU or ECU stabilization initially. So that would be my first go-to in instability cases. In really recalcitrant cases, I think an interpositional arthroplasty is a good salvage.
Okay, great. Thank you, Tamara. So Dr. Sartorianos, your allograft interposition, kind of the more bulk, the better. Is that your go? Do you do an interposition on even a standard DRUJ on a rheumatoid? And are there patients that you feel that it's not enough to control stability?
Well, Jerry, the way I look at this is I think you can pretty much lump Darrach, Hemi-Resection interpositions, matched resections, and Suave Kapandji all together in one category. My belief is that rheumatoids do very well with simple Darrach resections. The literature points out that rheumatoids are very low energy group that can do very well with the simplest of procedures. So I myself never do anything more than a Darrach, as Peter Stern described, for the rheumatoid. Now, getting into the other class of young warriors, if you will, then you have to look at the procedures such as the Aptus or the Shecker prosthesis, or something like the procedure that I described. That category of patients will require some type of interposition and stabilization. And I think that my procedure and the Shecker procedure can both be lumped together. Now, personally, as Tamara pointed out, I believe that I would never put an implant in a 44-year-old motocross driver. I think that you're asking for disaster in that kind of situation. In that case, I would definitely do an interposition arthroplasty. And I have plenty of mechanics and laborers that have gone back to work with that procedure safely. I've not seen any major complications with a volar dorsal type of instability, providing that you fixate the graft well to the ulna and the radius. So I think I commend all of the authors. You guys have all done a great job with your presentations and pointed out the nuances of each procedure. But I think you have to classify these procedures differently based on the patient and the low demand patient versus the high demand patient. And I think you all know what my belief is for the high demand patient.
Yeah, great points, Dean. Thank you so much. So Dr. Zalouf, do you do an implant prosthesis for every DRUJ patient that comes through the door? Or what are your limitations on what you wouldn't do it on? And is it too much surgery for a low demand rheumatoid?
Well, I think implants should be used selectively. I think the ablative procedures can be effective in a lot of patients. I think the problem with them is we all know that, as pointed out in all the particular talks, that 15 to 20% of the patients are not doing very well. That leaves you with 80% who are good. The question is the 80% really good, or is it just sort of acceptable? An implant, they're grouped together, but the problem is, I think, the constrained implant, which is the Shecker implant, obviously, is a constrained implant. I mean, when you really look at it and mess with it, you can tell that it's constrained. There really isn't a lot of translation in dorsal palmar as is seen in the normal kinematics. So I think selective use of that implant is appropriate. I don't really think it should be used primarily in most people, certainly in younger people. But I think what we're forgetting is Jorg van Schoonhoven's original study using the Martin prosthesis published a follow-up on patients with a minimum follow-up of 8 to 13 years, a follow-up of 8 years minimum, up to 13 years, with no degradation in time after the original study, which was published in 2000. So it's not just about a constrained implant. I mean, the ulnar head implant, which was the original Martin prosthesis designed by Tim Herbert, really has stood the test of time, done properly with good soft tissue surgery. The problem is it does require good soft tissue surgery, and if the soft tissues are deficient, then the usage of that prosthesis, if you can't secure it, is problematic. And in that case, if you are going to use an implant, then you would need a constrained implant that doesn't rely on the soft tissues. I think in that motocross racer, I heard a lot of negatives about using an implant, but as Chase showed, the Hemi implant, when there's only disruption of the articular surface and the ulnar column with the ulnar carpal complex, the TFCC, the foveal attachment, and the ulnar carpal, the ulnar triquetral and the ulnar lunate ligaments being intact, that can be effectively treated with the Hemi implant. And I really don't necessarily have a problem with that in that motocross racer. Despite his age, I think they can have excellent results. So I think you can't have one prosthesis fits all. I think it depends on the situation. I don't think you should ever say I would never use a prosthesis. I think you need to individualize. In a low demand rheumatoid, I think it's probably unnecessary, but you can have some excellent results. But I think one important point about the rheumatoid is you have to consider what the wrist looks like, the radiocarpal joint. If the radiocarpal joint looks like it's bad and it's going to need a wrist fusion, I would be very cautious about using an implant. It's a lot of stress on an implant, and in particular, a constrained implant. In the setting of a fused wrist with a constrained implant, that's a recipe for a real problem. So I'd be very reluctant if the rheumatoid looked like their radiocarpal joint was not very good and potentially would need a fusion. I would definitely not use a constrained implant, and I would be very cautious about even using an unconstrained implant.
Great, no, great points. So on a rheumatoid patient with both DRUJ and radiocarpal erosion, is your go-to perhaps a total wrist fusion combined with a DRA or some type of Hemi-Resection? Is that your kind of preferred algorithm for that?
I think it depends on the rheumatoid patient, but certainly that's the most predictable option. Would not be a wrist implant, meaning a radiocarpal type joint replacement. I would be in favor more of a wrist arthrodesis. Sometimes you can get away with a proximal row fusion, especially since most rheumatoids, the primary involvement is the DRUJ, secondary involvement is the radiocarpal joint, and the midcarpal joint is often.
Right, thank you, great points. So
just a total wrist fusion. I have performed selective radiocarpal fusion with a distal sphenoid excision.
Okay, great, thank you so much. Doug, are you still there? Is Doug Handel still there, out there somewhere? I'm gonna ask Doug for his thoughts on kind of part of his series that I did with him on checker prosthesis, also conquering the radiocarpal DRUJ combo. Lee Osterman, any thoughts on kind of your algorithm on kind of the presentations that we gave here? All right, bad timing.
Yeah. Can you hear me?
Yep.
Oh, good. Again, I would agree with pretty much all the comments made by the mentors. The amazing thing to me was when the checker first came out, I said, this is Rube Goldberg. This isn't going to work in a million years. It's going to loosen and have a bunch of issues. And to my surprise, I've become converted, as Doug and Jesse have, because we were seeing mostly salvages. And Dean's point that his procedure and this are in the same category. They're really salvages for salvages. And so most of the cases that you saw, particularly standard rheumatoids, I think you solve the ways that were solved. I love the Suave Kapandji in a rheumatoid. I think it provides a buttress. I think it makes a normal looking wrist. And then a little old lady with a bad fracture who can't rotate, I think Peter's Darrach has proven to do well. One thing I would ask Peter is Darrach's original description was a volar approach to resect the distal ulna. And we've kind of gotten away from that. And it's actually, when I do a Darrach, I do a volar approach, and it's much more stable than doing our classic dorsal approach. And I wonder if Peter has any thoughts on that.
Yeah, I think we lost Peter there. I think he has another webinar, unfortunately, to attend to.
All right, didn't seem to.
Any other comments or thoughts from other faculty? I know we're coming up to 5:29 now on the West Coast. I know there's a separate webinar starting soon, but really want to thank all the fellows and mentors for an outstanding, phenomenal job today. Any thoughts from Warren or any other faculty on the webinar today?
I think it was a great job, great points, and everybody had a convincing argument for their procedure. And the reason that we've chosen topics like this is because there's not clearly one right answer for everything or one wrong answer. So I think that's what makes this enjoyable. So great job putting it together, Jerry.
Well, yeah, thank you, Warren. I think this is what's great is I think all 4 faculty and fellows kind of really talked about really having the entire toolbox available to you, that every patient should be treated differently. And I think we talked about different classes of patients that Dr. Satarinos talks about, your low demand rheumatoid versus your high demand motocross racer. And really just having the entire armamentarium under your in your toolbox there. Well, it's now 5:30. Thank you, everybody. We will be coming back in a couple of weeks. So Dr. Richard is going to be hosting one on ulnar carpal abutment. And stay tuned. Stay safe and healthy, everybody. Thank you.
Thank you, Jerry.
Thanks,
Great
Jerry.
job.
Thanks, Jerry.
Thank you.
Thank you.
Dean, you lost.
Thank you.
Thanks, everyone.
Yeah. I'll take you on in the ring any day. Have a good one, everyone. Good evening.
All right. Thank you. Hey, Warren, so I'll touch base with you on kind of beyond into August in terms of what we should do as far as debates and timing everything.
Okay, yeah, that sounds good. We got a little bit of time, but I think getting that set because there's going to be a lot of people I think that are interested in doing it, and so I think that'll be good.
That sounds good. Have a good night, everybody.
Yeah, very, very nice presentation of essentially how you could use all of the techniques. So great job putting all those together, Jerry.
All right, no, thank you. Appreciate it.
So, okay, stay safe. We'll talk soon.
Yeah, sounds good.
Okay, bye-bye.